One with little. Okay, good morning. My name is Dr. Nelson Garias. The class is MED285, and this is now Chapter 7, Junctional Dysrhythmias. Now, as like last week, the problem was atrial. So it's everything that had to do with the SA node, everything that had to do with the P wave. So let's just jump right into it. And everything, all the problems in this chapter have to do with the AV junction, the atrioventricular junction. So last week the problem was all SA node, P wave, right? Now it's the AV node. So it's the problems now are here. Okay? So before the problems were here, the SA node. Now the problems are in the AV node going down that pathway to the bundle of His. And now you know why you have to practice. What do you call that? You had to practice and had to learn the first couple of weeks what the SA node, AV node, and bundle of His, because now you know all of this stuff is related. So let's look at this. How do I know I have a PJC, a premature junctional complex? If you look at this one, you already know that what? This looks weird. But it wasn't like the PAC. The PAC, we know there was something really wrong with the P wave, and it was really smushed up almost against the beat before it. But when you look at this beat, it's only slightly irregular. It's not, and then you got all the waves. But what's wrong with this is, if you look at this, that's P, Q, R, S, T, right? This one, P, Q, R, S, T. Good. P, Q, R, S, T. P, Q, R, S, T. P, Q, R, S, T. Now, where's the P? It's missing, isn't it? The P is getting gobbled up by that last T wave. And that's how you know it's a PJC. When you were looking at the PACs, the P wave was there. It's just smushed up. Nothing's smushed here. And this looks way more regular than a PAC. So a PJC, you know it's a junctional problem, hence the J. And what's missing? P wave.
P wave.
And it's only slightly irregular. Okay, so that's the best way to look at it. So now when we're looking at this one, which one here is the PJC, A or B? Both of them could be it, couldn't it?
Mm-hmm.
But let's look at all the waves in A.
Okay.
This one looks messed up, right?
Mm-hmm.
So this is P, Q, R, S, T, P, Q, R, S, T.
Yeah.
Okay. And there seems to be P, Q, R, S, T. Okay, so that one has all its waves.
Mm-hmm.
So that can't be a premature junctional. That's a PAC. Because see, this one's all smushed, but all the waves are there. But let's look at this one. P, Q, R, S, T, kinda. It's kinda missing. And the other ones look normal. Would you see how it's like there's no bump? It's almost flat. It's not even 1 millimeter in deflection or 1 millimeter high. So B is the correct answer. Now, on an exam, I'm not going to do this to you. This is evil if I do this to you. This is so mean. But what kind of questions would I ask you? Are all the waves there? I'll show you a trace B. Are all the waves there? And you'll answer no. Can I do this? Which one is the normal one? A. Which one is the abnormal one? A, B, C, or D? And you'll tell me what? B. I could ask you, what's abnormal about it? It's early. And since it has all the waves, I could ask. I'll ask you, does that look like tachycardia, bradycardia, premature junctional, or none? That's how I would ask it. I wouldn't ask you to do PJC versus PAC. But you can tell right now. You can do it. You can do it if you had to. right? So it's not that bad. Oh, I can tell you right now, there are a lot of my physician colleagues, they couldn't tell the difference between a PJC and PAC.
Oh, really?
They'd say, oh, call cardiology. No. The next one is junctional escape. Now, what does that mean, junctional escape? You see on the SA-AV bundle of His, it's a pathway, right?
Mm-hmm.
So what happens if the electricity jumps and escapes and goes the wrong way? So if it goes the wrong way, you think all the waves will be facing the right way.
Mm-hmm.
We know on leads 1, 2, and 3, it goes AV, it goes AVL, and AVF. There'll be upright traces. So if something escapes, the trace might be going the wrong direction. So let's look at what an escape looks like. What do we notice here about the P wave? It's going the wrong way, isn't it?
Mm-hmm.
It's upside down.
Down, yeah.
So if you have a relatively slow, normal rate, it looks like NSR, but then you look at that like, why is the P wave like that?
Mm-hmm.
Well, guess why? Because I have a junctional problem. So how do you know you have a junctional escape? What does a junctional escape mean? The wave is going the wrong way because this is the pathway, right? SA, AV node, bundle of His. What happens? SA, on my way to AV, I take a left turn. I get lost. And you can see the camera is showing the wave is getting lost. And that's a junctional escape rhythm. That's an easy trace. You definitely know it's P wave. You definitely know it's an escape because it's going the wrong way. Who's texting me? So you can easily tell which one's bradycardia and which one's junctional escape. Which one's junctional escape, A or B?
A.
Easy peasy, right? So could I ask you, could I ask you if B, how about B? Is that tachycardia, bradycardia, or eucardia?
Probably bradycardia.
It's bradycardia. Because I can do my 6-second method. 1, 2, 3, 4, complete PQRST waves. 410 is 40. It's less than 60. Kabang. Okay? Easy peasy. But it's not easy when you put them all together.
Yeah.
But that's what you have to do when you're figuring out what am I looking at. You have to analyze. Now, accelerated junctional rhythm. So now I know it's going to be a little bit faster. So you know the escape is slow. But if it starts being normal rate and the P wave is upside down, you have an accelerated junctional rhythm. So right off the bat, you know the P wave is upside down. What are my choices? Right? Junctional escape or accelerated junctional rhythm? Oh, okay, let me check the speed. The speed on a junctional escape is what? Slow. The speed on if something's accelerated, it's going to be what? A little faster. And this will be normal. So let's look at, it seems like it's a normal NSR, so how many QRSs do you see? 1, 2, 3, 4, 5, 6, 7. 7 times 10, 70 beats per minute. Is that regular? Is that a regular rate? Yeah. So, but you notice that the P wave is upside down. So what kind of question could I ask? I could ask you, is that NSR, junctional rhythm, bradycardia, or tachycardia? And you'll tell me what? It's a accelerated junctional rhythm because the P wave is wrong. Or how about this? I can tell you outright. There is an abnormal trace. Is it the P, QRS, or T? And then you look at it. Oh, the P is sometimes non-existent, and on these other ones they're upside down. Then I know it's a P wave. See, this one's easy. This one's easy to detect. Which one's which?
Yeah.
Right? Now let's look at junctional tachycardia. Of course, that's going to be what? Even faster. And what was the main thing? Do you see now like a theme on a junctional rhythm? The P wave is not going in the right direction. It's not going SA to AV, the bundle of His. It's spreading out in an opposite direction, and it's fanning out in your atria. So the P wave will always be upside down. And now you have something that looks like tachycardia. You definitely know it's P wave because why? You know it's atrial because the P wave is all upside down. And then once you see the P wave upside down, this is how I remember it. Do you see how the J? So I think automatically J, junctional. And then I have my choice of junctionals. And you definitely know this is not accelerated because it's abnormal. You definitely know it's not just a regular escape because a regular junctional escape is what? Slow. Okay? Last. Okay. So between A and B, which one's the junctional tachycardia?
A.
You sure?
So B.
Right? Which one has the obvious upside down waves?
B.
It's B. They're both tachycardia, but then I gotta look. Well, I got the PQRS seems smushed. That's not a medical term, smush. But do you see how the P wave is like still there?
Mm-hmm.
But it's going so fast that it's bumping up against the previous T wave. But this one, you can now see that what?
Yeah.
The P wave is almost non-existent, and this thing's like whoop.
Mm-hmm.
That's not good. So that's got to be what? That's got to be a junction. Now another type of junctional is SVT. SVT. Supraventricular tachycardia is yet another emergency trace. How do you know this is bad? First of all, it's tachycardia. Tachycardia is never good. Do you see there's no more P wave? And it's so fast that the previous S wave, the previous T wave is wide, and so is the QRS. Know that trace. That is a very important trace. You see that, you stop you see that, or atrial fibrillation with no history, you stop, you inform your chain of command immediately. Your patient will be symptomatic. That means it'll be obvious that there's something wrong. Another type of junctional is Wolff-Parkinson. That's doctor stuff. But it's the same problem. So if I asked you, Wolff-Parkinson White, what is it? You should be out. You should be able to look at the trace. You should be able to identify the trace. But WPW, if you see that, you know it's a what? It's a junctional problem. It's the problem between my AV node and the bundle of His. And Wolff-Parkinson White syndrome is very, very rare. Out of all the patients that I've ever seen through medical school and my years practicing, I've only seen one. It is weird. I was sitting there looking at it, and I know that's wrong. I know it's a junctional, right? So my initial diagnosis when I was and the gentleman, he was 29 years of age. He came in because he thought he was having an asthma attack, but it was what? He was having a heart problem that was backing up pressure into his lungs, and then it made him feel like he can't breathe. When in actuality, he has a junctional heart problem. And I remember just standing there, I'm like, it's junctional, but I can't, I didn't memorize all my traces, but I understood what it was. And then a cardiology fellow, someone who's in advanced cardiology training, she stood up and she goes, "Oh my God, that's WPW." And I go, "What?" And I go, last time I saw that was like medical school. And it was like a trivia question. I think out of 2,000 cardiac questions, maybe it'll be 1 out of 1,000. But I caught up with it. He was my patient, and I'll remember it. And that's how you remember it. You remember it via stories. Okay? Now, SVT, very bad. Okay? And you can see is SVT, the patient will be symptomatic. They'll start complaining. And with a lot of the serious heart conditions, there's something called a feeling of impending doom. They think they're going to die. Especially an acute myocardial infarction, they're going to think what? "Oh, doc, there's something wrong. Oh boy." Stuff like, I feel palpitations. Palpitations when you can actually feel your heart beating. That's not good, right? Or my heart is fluttering, or I feel my chest vibrating. And then you put your hand on there, All right, you put your hand on there around the fifth intercostal space, midclavicular line left. Ooh, you'll feel it. You'll feel it. And they get unstable really fast. So that's SVT, just like AFib, is a very scary trace. Okay, let's look at. So that was a quick chapter, but you know these questions at the end of the chapter, they're nice. Well, what's more important now that you had that quiz?
Mm-hmm.
You know what's more important is what?
Yeah.
The pictures.
The pictures.
So you go straight to what? You go straight to the pictures. So number 12. Let's see what's wrong with it. Do you see any P waves?
No.
And it's slow,
Mm-hmm.
right? So what do we know that? What do we know that if I have no P wave and it's slow and it looks irregular? I mean, it looks like a regular late. Then you got to know it's a what? What does that look like?
The junctional escape.
It's a junctional escape. How about this next one? It looks just like the one before it, but it's a little faster, just a little.
Mm-hmm.
1, 2, 3, 4, 5, 6,
But it's
7
like
beats.
better at the escape because it's going down the.
So this I know, because this you know, it looks just like the one before it. There's either no P wave or the P wave dips a little bit. So you know that's junctional, but it's not slow. It's normal speed. So that's got to be a accelerated junctional rhythm.
Okay.
Okay, how about the next one? You definitely know this junctional problem. Is it fast or slow?
The junctional tachycardia.
It's junctional tachycardia. That's right. See, now when you could kind of understand and lump them all together, it's not that bad. And when you really think about it, it's actually a story. It's actually a progression. So if my patient has a junctional problem, they're going to start off with what? They're going to start off with a junctional escape. Then it's going to start with normal. Then it's going to start then there might be a skip. Then there might be what? It starts going fast. And then when it goes too fast, it looks like SVT, and that's a problem. Do you see how it's actually not four or five problems? It's the progression or the story of one problem that got worse and worse and worse. Now here's the problem. All those other rates weren't really that bad, so the patient's not going to notice it until when? They have SVT and that's already late. That's already a problem. Here, another junctional escape, and how do we know? No P wave. Junctional tachycardia. Here's a little early, so that's how you know it's a what? PJC. Okay, and there's several more, and another PJC. You can see it's like wash, rinse, and repeat. And of course here, ugly, ugly, ugly SVT. SVT, scary. Do something. Stop the machine, call your chain of command. Okay, go through those. And that was quick. Barely fighting to stay normal. Look at that, Chris. That's not good. It's and the atrial it is. Now, flutter. Can you tell the difference? Which one's atrial flutter?